Okay, recording has started. We will have a few minutes after the presentation for the speaker to answer any questions. To ask a question, please enter your question into the chat, and I will ask the speaker after the presentation during the Q&A period. My name is Phil Meir. I am the program manager with the American Nurses Association in New York, and I have the pleasure of introducing our speaker this evening, Dr. Carla Gerritsen. Dr. Gerretsen is currently working at Roswell Park Comprehensive Cancer Center as the Director of Nursing for Ambulatory Services. Her previous position was as a nurse practitioner and Director of Oncology Services at Erie County Medical Center, where she helped implement and develop the Transgender service line. The program has grown to now include a dedicated patient navigator, a psychologist, and ECMC achieved leader status in the Human Rights Campaign's LGBTQ Healthcare Equality Index for the second time in 2022. Without further ado, I would like to welcome Dr. Carla Gerritsen.
Hi, everyone. Good afternoon. So sorry about the technology problem. Those kinds of things always happen, right, when we're trying to do these things, but we will get the slides out to you, I promise. So I'm just going to start real quick. I'm going to skip a couple things as I read off my slides here. A couple quick definitions that I wanted to touch base on. I did want to focus mostly on the medical aspect of transgender care and gender confirmation surgery. Just kind of go over what our challenges were at ECMC, what we struggled with, how we overcame some of those barriers, some things that maybe you would anticipate or expect when you're taking care of a new service line of any type, right? And then things that we would still experience. I did just leave ECMC, full disclosure, about 4 months ago. They had asked me to present this before that time, and my navigator normally also co-presents with me, but unfortunately today she had another presentation herself as well. So you have just me today. So a few things that some of you may or may already be familiar with as far as definitions, things that we're using more frequently. Sex assigned at birth is the sex that or gender that the person was born with. So this is based on the appearance of the external genitalia. For most people, their gender identity and their expression are the same as that they're assigned at birth. Sexual orientation is a person's preference for a sexual partner, and gender identity is a person's sense of being male, female, or non-binary. And this can be very fluid, as we're seeing of recent. Some people are transitioning. They're trying to determine what they're comfortable with, what gender they want to be with, and as they transition, and how they're comfortable in presenting themselves. Gender dysphoria and gender identity disorder are two terms that are continued to use in the medical world when we talk about gender. In the DSM-4, it was defined as gender identity disorder, which was defined as a strong, persistent cross-gender identification and discomfort with one's gender role, which caused clinically significant distress or impairment in social, occupational, or other means of functioning. It changed in the DSM-5 to gender dysphoria, which is defined as the discomfort or distress that is caused by a discrepancy between the person's gender identity and their biologic gender. I know there's some controversy over the use of these terms because not everybody who has a gender preference or uses a different pronoun than their gender assigned at birth likes the phrase gender dysphoria or gender identity disorder. However, we do have to continue to use it, as these are the things that we're limited and using as far as medical terms, ICD-9, ICD-10 codes, etc. And I have a slide about that. When you get the slide deck, you'll see those. So in 2015, there was a U.S. transgender survey that went out and involved thousands of transgender patients, and it really was looking at a lot of different education, how they felt psychologically, things like that. And a couple of the factors that really wanted to point out with this, and I wish I had my slides, and I'm so sorry I don't, but 60% stated that they were out to their immediate family and had supportive families, but 50% of those 60 said that they did feel they experienced rejection in at least one form from an immediate family member, spouse, or child. Another important fact I wanted to point out is that only 11% of respondents reported that all of their IDs had their preferred name and gender. And this is a really important fact. This is something that we run into a lot at ECMC when I was there, is incongruence of patient's ID. And I can touch base on that in a little bit as far as how that can lead to some difficulties for us. 68% of respondents indicated that none of their IDs had their preferred name or gender on it. 25% reported issues with their health insurance, such as being denied coverage for routine care or care related to their transition, and 23% said they had not seen a doctor due to fear of being mistreated. So the ICD-10 diagnosis codes are somewhat restrictive still in their definitions and their names. They use words such as transsexualism, dual role transvestism, gender identity disorder of childhood, gender identity disorder unspecified, and then a personal history of sex reassignment, which is Z87.890. All of the ICD-10 codes currently are classified as mental, behavioral, and neurodevelopmental disorders and fall under a DRG code of 887, which is a mental disorder diagnosis. The reason why that's important to point out is because what we found through the years is when we're coding and billing for certain procedures, we're only getting reimbursed at the level of a mental disorder diagnosis under that DRG code of 887. So we're doing large surgeries, patients are in the hospital for 5 days, 7 days sometimes, and the reimbursement rate for this is very low still because of that. I think that also partially contributes to why so few facilities want to consider getting these programs up and running, even though it's a good service, just because reimbursement codes are so low still. The other aspect of billing that we have to take into consideration is we have to use modifiers such as 45 frequently, which indicates the insurance company that this is a procedure for gender other than is listed on the patient's insurance card. So if the patient is listed as male, for example, on their insurance card, and that's their gender assigned at birth, but they're transitioning to female, and they need a procedure that is a male procedure, no, that's opposite. Then you have to use the code 45. Trying to think of a good example. A female to male patient. So they may have their insurance listed under their male name, their male pronoun, but they need a mammogram because they haven't had breast surgery yet. Then that's where you're going to use code 45 to indicate that even though on their insurance card it's listed as a male name and a male gender, they still have some female organs and still need female care. So all of this confusion with modifiers and insurance and incongruence of patients' genders on their ID is oftentimes what keeps people away, because it's difficult to go through that. We have a patient, for example, who has not changed their legal name yet, and all the billing and coding still goes to that patient's male name, and she's called us multiple times requesting, can we try to change that? She doesn't like that, somebody could possibly see her male and see the male name on it. But unfortunately, we have significant limitations with our computer systems and our IT systems that don't allow us to put in preferred name for billing. We can do it in our EHR, but we can't do it in our billing yet. So these are all little barriers that we have to think about when we're moving forward. New York State law is something that we follow pretty strictly as far as considering people for insurance purposes and for surgery and other. Just dropped my PowerPoint. The New York State law indicates that the patient has to be at least 18 years old. They require 2 letters of clearance. It became a little less strict recently, I would say in the last year or so. Initially, they needed one from a psychiatrist, MD, or psychologist, and they needed a second one that needed to be from a psychiatric mental health nurse practitioner, psychiatrist, or psychologist. However, they've opened it up now to also allow licensed clinical social workers and other mental health counselors to also provide those letters of clearance. So that's allowed a lot more availability as well. One of those letters has to be from somebody who has an ongoing relationship with the individual, and a second needs to be from somebody who's purely evaluative. So they have no relationship with the individual. They're just there to assess the individual and determine clinical clearance for us. What we've done at ECMC is we don't require our psychologist do that second evaluative role, but we do have her there available for that, because it can often be difficult for a patient to find somebody who's willing to do that for them or who meets that criteria. So we have that available to them. New York State also requires that the patient's been on hormone therapy for a minimum of 12 months. They must have lived in the gender role for a minimum of 12 months, and they must have capacity. There's multiple therapies that we can use. There's medical endocrine hormone therapy, psychologic therapy, as well as surgical therapy. We tend to not use the word treatment because we feel that that stigmatizes gender identity as a disorder. Unfortunately, though, we still have to use disorder in some phrases due to our coding still. New York State covered services will include mastectomies, hysterectomies, oophorectomies, vaginectomies, as well as phalloplasties, vaginoplasties. What they will not cover usually, though, is anything that may be deemed cosmetic. So breast augmentation is one thing that's questionable at times. If the individual has completed 24 months of hormone therapy and there's not much breast growth, then they will often consider breast augmentation as a covered service. Frequently, what we would have to do is get authorization from the patient to share photos and their information with the insurance company. We would take photos, usually a front view, a side view, and send them to the insurance company so that they could see how little breast growth there was in order to get that covered. In order to initiate hormone therapy, they must meet the criteria for a diagnosis of gender dysphoria. They must have reached at least a Tanner stage 2 and have no other psychiatric comorbidities that would interfere with their diagnosis. They must also be able to demonstrate knowledge of the risks and benefits of hormone therapy. We achieve feminization through suppression of androgen effects. Most commonly, we'll place patients on spironolactone. And then we will induce secondary sex characteristics with the use of estrogen. Labs must be checked frequently. You want to assess their electrolytes, testosterone levels, and you also want to assess estrogen levels as well. You usually will see some thinning, slowed growth of the body and facial hair within about 6 to 12 months, and that maximizes out at 3 years. Some decreased testicular volume in 3 to 6 months. You'll start seeing some breast growth in 3 to 6 months, and maximum effect of that is usually around 2 to 3 years, which is why the state recommends waiting at least 2 years before deciding if they're going to cover breast augmentation. Some risks of feminizing hormones that we feel are most likely a risk are cardiovascular disease, hyperlipidemia, as well as elevated liver enzymes. You may also see an increased risk for DVTs as well, just like anybody who's on estrogen. Unclear if there's a risk are type 2 diabetes and hypertension, and it's really inconclusive right now about the risk of breast cancer. We do know that some breast cancers are estrogen and progesterone driven, so only time will tell with that. Unfortunately, I think we're really early in medical care and in hormonal usage for us to know, if in 10, 20 years from now, the estrogen use will have any effect on those kinds of cancers. We'll masculinize patients through the use of testosterone. The most common is testosterone cypionate. That's given IM. You're going to want to check peak and trough levels for those as well, and make sure they're in a therapeutic range. Monitor their CBCs and their liver function tests as well. You should start to see facial and body hair growth within 1 to 6 months, with a maximum effect after about 1 to 2 years. You're going to see increased muscle strength within 6 to 12 months, a deepening voice within 3 to 12 months, and vaginal atrophy within 3 to 6 months. Risks of these hormones, you're going to see some polycythemia, some weight gain. You might see some visceral fat as a result of the vaginal atrophy. If they do not proceed with surgery, they may have some pain, difficulty with having pap smears done as well. Possible increased risks, you may see some mania or psychotic symptoms, and inconclusive still is the risk of osteoporosis. And if they retain their female organs, endometrial, uterine, and ovarian cancers, again, still unclear as to what the impact is on those. For psychologic care, usually the initial goal is you want to assess the level of gender dysphoria. You also want to talk to the patient, assess them, treat any coexisting mental health concerns. There is a certain rate of trauma in the past with some transgender patients, whether it's from abuse because of their transitioning, so it's abuse from their family members, whether physical or sexual, some depression. We may oftentimes see sometimes polysubstance abuse as well. So you want to get them optimized, get them healthy in a good space, and be able to support them through their transition. You want to make sure that they have adequate peer support or family around them, somebody to help them, because as they're going through surgery, it is very difficult. There's a lot of doctor's appointments, and there's sometimes side effects and things that they will experience, that we want to make sure that they have somebody there to support them who's close. We also want to make sure that they're set up for success with lifetime care. So a lot of our patients that we would see have multiple surgeries. So they may start with, if it's female to male, they may decide that they're going to start with just having mastectomies bilaterally. They may eventually decide to have a hysterectomy and possibly a phalloplasty. So we would need clearance before any of those surgeries. So each time they have a surgery, we're going to be requesting a psychologic clearance. So we strongly recommend that they maintain a close relationship with their psychologist. One of the things that we did run into was e-therapy, online and distance counseling. I do remember one of our patients presented with letters from someone in the UK. We had no way to confirm that person's licensing status, their eligibility to assess and treat somebody. So we unfortunately were not able to accept that. We have really put a policy into place that we would only accept telehealth with local providers or providers in the state that we can confirm their license and know the legitimacy of that provider. Unfortunately, there is some predatory practice going on with e-therapy and online distance counseling, where they're charging large amounts of money to get letters of support for our patients. And luckily, I only did see it once, but it's definitely something that we will not accept at ECMC. We really try to link them as much as possible with a local provider. That's part of the reason why we had developed the navigator role in our program. So Sarah Clark is her name. She's our nurse navigator. She's been with the program for quite some time now. When a patient demonstrates they have interest in surgery, she'll be the first point of contact. So they'll call the office and they'll get transferred to Sarah. Sarah does a baseline assessment. She'll see if they're seeing anybody now for from a psychology perspective, a social worker, a counselor, anybody. Work with that person and that team to get their records, see how they're doing, and then also help link them for a secondary evaluative consult as well if they need that, whether that's at our local Evergreen. I don't know how many people are from the Western New York area, but we pair with them a lot, use some of their counselors. We also have some relationships out in Rochester that we will pair with as well. And again, our own psychologist will see them as much as possible. And she really makes sure that they're linked and doing well. And then once they have both of those letters in place, then she will actually work with our surgeons to get them in for a surgical consultation. It's a really good process. I think it works really well because we're able to maintain contact with the patients. We're able to help them through ups and downs of therapy. Some of the patients will be working with Sarah for a year, 2 years before they're even ready to move forward with surgery. And that's just a service that we provided them. We don't charge their insurance for anything. We just want to make sure that we're helping them navigate through this and get them to surgery so that they can be successful as much as possible. Surgical candidates must meet minimum criteria in order to be considered for gender-confirming surgery. There's the WPATH standards, and there's also New York State law. WPATH is the World Professional Association for Transgender Health. There is a variance, though, between WPATH and New York State law, and frequently people will come in and point that out to us, but we really have to state that we have to follow New York State law and we have to follow what the insurance companies are requiring. So WPATH only recommends 1 clearance for breast surgery and 2 for genital surgery. However, we do require 2 clearances for breast surgery as well. So we have to make sure that they're aware of the fact that we're following what New York State law indicates what the insurance companies require as well. At ECMC, the surgeons also require smoking cessation because of the risk to wound healing, skin flaps, and other things like that. It can be prolonged healing if they're continuing to smoke. So we do make sure that they are no longer smoking, and we will test them for tobacco usage as well. So we'll test them a few weeks before their scheduled surgery, and then also usually within 24 to 48 hours before surgery to make sure they're nicotine free. One of the barriers in scenarios that we ran into at ECMC was definitely an insurance carrier issue. Again, certain things that you're not thinking about. You think everybody that resides in New York State is going to fall under the same scenario. However, here in Western New York, we have, Ford, and we have Chevy and, other companies like that their carriers out of Michigan. So GM and Ford employees often have Michigan-based insurance, and Michigan laws are not the same as New York State. In New York State, it is required coverage that patients are able to get transgender care, whether that's psychologic, hormone therapy, or surgery. However, we do have some patients that come in and they have out-of-state coverage. Other situations you might run into that are Amtrak employees or people who work for companies that are not based in the state. Surgical treatment options. There's multiple options you can do to feminize. You can do facial feminization, tracheal shaves, body contouring. Really, the only thing that the plastic surgeons at ECMC focus on are vaginoplasties, breast augmentation, and phalloplasties, as well as vaginoplasty procedures. Pre-operative, before a vaginoplasty procedure, like I stated, we want to make sure that we have the patient all set up, that we've got both of their psychologic clearances in place. We make sure that we get prior authorization from the insurance. Sometimes that's pretty easy. Sometimes it's a hurdle, a few hoops to jump through to get that taken care of. We get a preoperative medical assessment as well, make sure they're healthy to undergo anesthesia. Sometimes we may have them consider electrolysis because the way we do it is a penile inversion procedure. So if there is any penile hair, when you go to do the inversion procedure, sometimes there may be hair growth in the neovagina. It is not a covered procedure, however, so the patient would have to pay out of pocket for any electrolysis procedures. The same for phalloplasty procedures. If the patient has a hairy arm, that may be difficult. It may result in some difficulties in the surgery as well. So we do recommend electrolysis if they can afford it. We have the patient hold their hormones for 2 weeks prior to surgery because of the increased risk for DVT. They're on a clear liquid diet for 24 hours prior, and they also do a bowel prep. And again, they remain NPO after midnight, just like any other surgery. A couple slides here. When we get these out too, you'll be able to see how a penile inversion vaginoplasty works. But essentially what you're doing is you're taking the scrotum and the tissue from the scrotum, and you're using that to create the labia. The head of the penis is used to create the body of the clitoris so that the patient would have sensation and some sexual pleasure. You will also use the shaft of the penis, invert that to create the vaginal vault. I'm so sorry. This thinks I can't see my pictures. Post-operatively, the patient will be on a post-op unit for about 5 to 7 days, strict bed rest. They will have vaginal dilator packing in place for a few days to maintain patency. The Foley catheter will remain in place until the packing is removed, usually around post-op day 5. They'll have some JP drains. We usually remove those before they go home. About 5 days after surgery, the packing will be removed. They'll be sent home with pain management, prophylactic antibiotics, and they're told to continue to hold their hormones for a little while as well. Once they follow up with us, they'll get a peri bottle to help them clean at home. We encourage them to shower and bathe. We want to wash the wounds daily. We do have to frequently teach them to wash from front to back to avoid contamination. A lot of things as a female, born as a female, living as a female my whole life, never thought, about those kinds of little things that we have to teach to patients, but we definitely have to remember to teach them to wash from front to back, washing their hands before touching any of their wounds, and we do recommend douching with tap water only. Once the wounds have healed fully, then we do recommend dilating, and we do provide the patients with a set of dilators. They're going to need to start with the smallest size. They usually use that size for about 3 months, and then they'll slowly move up over time. They're going to dilate about 3 times daily once the vaginal packing is removed. For the first few months, we recommend 3 times a day for about 10 minutes each time, slowly putting the dilator in, turning it a little bit, and leaving it in place for about 10 minutes and then turning it. After about 3 to 6 months, they can usually go down to once a day. 6 months after that, they can go down to 2 to 3 times a week. And after 9 months, we'll say 1 to 2 times a week, or depending on usage. So if they're highly sexually active, they may not need to dilate as much. Multiple complications can occur, but I would say the most common are pain, urinary tract infections, swelling. Sometimes you can see partial flap loss, wound healing problems. The most common area where we see the wound healing issues is in the perianal area. There's some dehiscence there sometimes. Initially, there will be urine stream abnormalities. We do tell the patients that because of the swelling is often uneven, the stream may go to the side, right or left, and then as the swelling goes down, they'll notice a more normal stream. Also, we will see inadequate vaginal depth and sometimes stenosis as well. Sometimes patients will request revision surgeries, whether that's for cosmesis or for function. Phalloplasty is similar as far as the pre-op requirements. You're going to hold your hormones, NPO after midnight. We will typically do this in stages. We'd recommend a hysterectomy first. Then we would do the vaginectomy with urethral reconstruction, and then go back later and do a phalloplasty using free tissue transfer. You can use an anterior lateral thigh flap, but the most common is the radial forearm free flap. Radial forearm free flap is a tube-in-tube type of reconstruction. So you're going to take the tissue from the forearm, you're going to de-epithelialize part of it. The first section that remains with epithelium, you're going to roll onto itself. You're going to put a Foley catheter in, and that's going to create the new urethra. And then you're going to continue to roll the flap over the de-epithelialized tissue. I know it's probably difficult to picture all of this, in order to create a long tube-in-tube type of flap that we would attach and use that as the phalloplasty procedure. Quickly going through my slides. Post-op, the patient usually will go to the TICU for the first day or two because of it's a free flap, and so we want to make sure that they're performing frequent flap checks, checking for Dopplers, things like that. Usually by post-op day 2, we'll send the patient to the floor. They'll be on bed rest for the first 5 to 7 days. We do a special cloud type of dressing, which is Curlex with gauze wrapped around the neophallus that we put under there to support it and allow it to heal adequately without dehiscing at the surgical site. They will have a suprapubic tube in place as well as a Foley catheter. The penis should be positioned upright with gauze bandages while it's healing. We'll send them home on pain management as well as antibiotics, and we'll see them back in the clinic afterwards. Often complications are dehiscence, UTIs, urethral-cutaneous fistulas, and urinary strictures. We have seen quite a few urinary strictures. We've had to do multiple procedures to try to reduce strictures. You'll often leave the Foley catheter in place as well as the suprapubic tube in place for as long as possible to prevent those strictures, but they still will occur at times. As far as lifelong medical care, for trans female, surgery does not include a prostatectomy, so we need to keep in mind that that patient may still be at risk for prostate cancer. If a prostate exam is needed, we do recommend performing both a rectal and vaginal exam. You need to also counsel the patient related to genital hygiene, STD prevention, and sexuality. We recommend they follow up with a GYN as trans-friendly to perform urogenital tract evaluations. And they should continue to get breast cancer screening and a mammogram every 2 years starting at age 50 if they've had at least 5 to 10 years of estrogen use. One of the things that was Poignant for me, recently I attended a conference for navigation, for oncology navigation, and they were talking specifically about trans female patients and prostate care and prostate cancer. And they had a patient that presented and talked about her experience as a female going through treatment for metastatic prostate cancer. And it was really interesting and really brought forth a lot of thought to the fact that as we move forward and more patients have surgery and gender affirming care, we really have to focus on and think about treating all those patients with respect and understanding that they may have retained organs from their birth sex that we have to have them comfortable talking about with us and discussing, so that we can hopefully prevent metastatic prostate cancer by managing and caring for them and taking care of that through their lifetime, so that they're aware that that is still a need. In trans male patients, which are female to male, they should continue to have gynecologic exams if they continue, if they maintain their reproductive organs and they've not had any surgery. Cervical cancer screening should continue to be based on current recommendations. Again, this is something that can be very painful for them, awkward, uncomfortable walking into a gynecologist's office as a man there to have cervical screening. So we have to be very conscientious of that. If there's not been breast surgery, we recommend using current clinical guidelines for breast cancer screening. If they have had a mastectomy, there still may be a minimal risk of breast cancer associated with any residual breast tissue, but mammograms can often be very difficult, so they may need ultrasounds. We want to make sure that we're still taking care of cardiovascular risk, depending on the patient's age, how long they've been on hormones, other risk factors. There's no increased risk for diabetes, but we still have to consider that as a normal aging factor. Bone density screening should begin at age 65 or earlier. HIV and STD screening. And other education about disease risk based on their biologic gender. So cardiovascular risk, if you're at an increased risk for cardiovascular disease because of your genetics or your gender, you're still at the same risk profile, even if you've had surgery. So we do have to keep in mind all the time biologic gender, birth gender, to consider what somebody's risk factor is for certain diseases. As far as cancer screening and education goes, this is a very difficult topic because, we do know that right now large data sets such as SEER and the NCDB do not capture non-binary or transgender information. Hopefully that will be changing. They ask male or female gender, so it really makes it difficult to assess cancer risk in patients who are non-binary. Those patients who seek routine health care may be reluctant to discuss gender or gender incongruous organs. If you remember at the beginning, I talked about 23%, I believe, are comfortable talking to their physician about their gender assigned at birth and the issues that may arise with that and the fact that they're transitioning. So we have to really continue to provide an area of acceptance and comfort to be able to discuss these things so that we can make sure that they're not getting advanced cancers or diseases that could have been caught earlier just because they were uncomfortable discussing this with their providers. And again, the effect of exogenous hormones continues to remain unknown. We really don't know in 5, 10, 15 years down the road how that will impact disease. There is a really good article about cancer screening in the transgender population. I did put it in here as a reference, so when we send the slides out, you'll be able to look that up and review it as well. Fertility is also a discussion we have with patients. They need to know that they will be sterile. So pre-op, we discuss with them if they want to have a family planning, how can we do that for them? They also need to be aware that before surgery, they're still fertile, so they can get pregnant. So we have to discuss pregnancy prevention pre-op as well. Real quick, going through our experience at ECMC, we did the first case in June of 2016. Initially, the surgeons came in, they said, we're going to do this. They had a case booked, and we really kind of had to, after we did the first case, slow it down a little bit and make sure we had good processes in place, because we did run into a lot of situations and barriers. As of June of this year, they have completed 57 vaginoplasty procedures, and they have 6 scheduled. They've completed 15 phalloplasty procedures with 5 scheduled, and I will tell you that is not many more from when I last lectured on this topic, probably about a year ago, because of the COVID-19 restrictions that were placed by the state limiting elective surgeries. This surgery was placed on hold for almost that entire time. So we were doing some revision surgeries and things like that, but new patients were not receiving gender-confirming surgeries during that time. Barriers that we came up with were our EHR systems. Oftentimes do not include transgender options. The health record system now does. You can enter different types of pronouns. You can put in patient's preferred name. However, at ECMC, their billing system still does not allow for that, like I said before. So there's still maybe some issues with patients getting bills in the wrong name, depending on how they are, what their legal name is, what their documents are for their driver's license, what their insurance documents indicate. Another thing that we found was asking too frequently or inappropriately about patients' pronouns. And when we rolled out training initially, some people were asking everybody every time they came in about their pronoun usage. And there's just times when you have to say to yourself, okay, this is not the appropriate patient to ask that for. So one of the things that we put into place actually to help with that, because patients who hadn't been seen yet, we didn't have the ability to enter into our system if they had a preferred name or preferred pronoun as a new patient. Once they had been seen in our clinic, we were able to enter that as alert so that everybody in the clinic and the hospital knew what the patient's preferred pronouns were, knew the patient's preferred name, but that wasn't available at the first visit. So we actually went old school, back to paper, and as patients were checking in, we gave them a small form that asked them what their preferred name was, what their legal name was, and that made it really easy because even if it was, a 70-year-old gentleman who was there for cancer care or other types of care, he came in, his name was Charles, and he wanted to be called Chuck. He could write on that, he's Chuck, and it didn't result in any embarrassment for anybody by doing it that way. So it was our way to work around some of those barriers, and seemed to work pretty well. We did have to roll out a lot of staff education, as well as providers in our own hospital and providers in the Western New York area that may see patients in the EDs or other places once we discharge them. They didn't all live in the city of Buffalo or surrounding area, so if they wound up in one of different county, some of those patients would go to local emergency rooms outside of Buffalo. So we did have to make sure that there was awareness outside of our local area for that we were doing the surgeries and how to get a hold of us and what to do with certain wound care problems and things like that. So at the beginning, there was a lot of the physicians were going out, hitting towns and hospitals and really talking to people and going through it. So how do you change your practice for this? One of the ways to do that is what's called a trans care approach. So you want to treat transgender individuals with respect, as you would for all of your patients. Refer to transgender people by the name and pronoun associated with their gender identity. Ask politely how they wish to be addressed if you're unsure about a person's gender identity. Never reveal a person's transgender status unless it's absolutely necessary for the patient's health care. Set a high standard for inclusive care. Concentrate on care, not curiosity. Avoid negative facial reactions and offensive language. Remember that threatening a transgender patient is not always that treating a transgender patient is not always a training opportunity, and educate yourself and others about transgender health care and issues. And one real quick example that we had put together is kind of a quick case study is, you're in the emergency room and a patient presents who is male appearing. However, they still have a uterus, but they're not screened for pregnancy before you send them to X-ray. So that could result in a potential harm if the patient was pregnant. And then the other scenario, again, is a female patient who presents, who still has a prostate, but has urinary difficulties. How do we think about that? Is it BPH? Is there a potential prostate cancer? So we have to think about the sex assigned at birth when we're determining a treatment plan. We have to think about retained organs and what we would do for that patient based on that. So again, I apologize. It stinks I didn't have my slides up for you. I'm really sorry, but does anybody have any questions?
If anyone has any questions, feel free to put them in the chat and I'll read them to Dr. Gerretsen. No questions, but you were great even without the slides.
It would be so much better if you could see some of the pictures, but we will get those out for you because then that will make so much more sense than me just trying to describe what phalloplasty and inversion vaginoplasty look like. But I tried my hardest, so I apologize for that. I'm really sorry.
Let's see. This recording will be available. Since it's recorded, we will have it up on our YouTube channel. We got a few other questions as well. Kimberly has said, were there any hesitations on staff side caring for the patients?
There were, not with my staff. Luckily, the staff that we had in the clinic that we were starting the program in were all very supportive and accepting. We went to training together. There was a WPATH conference that was held in Washington, D.C. We went to that so that we could familiarize ourselves with a lot of medical care and processes before we went forward with the program so that the staff were comfortable. There were, however, in other areas of the hospital, some staff that when we started rolling out the training that were uncomfortable with it. We unfortunately, though, did have to, enforce a policy that you can't walk away from a patient who's in front of you. So if somebody was uncomfortable with taking care of a transgender patient for whatever their personal reason was, that was fine, but they had to, if somebody presented in front of them, we really, said that they couldn't just stand up and walk away from the patient because we thought that would be rude and uncomfortable for the patient. So we encouraged those employees to maybe take a non-patient facing position or something like that if they had to.
Another question from Gertrude Hutchinson. How would you go about asking about prostate or pregnancy issues if the trans person does not want to address their past identity?
Oh, that's a difficult situation, right? And luckily, for the most part, I think that most trans patients are open and do talk about their past. If you can give them a sense of comfort and acceptance so that they know that you're really here to do what's best for them. Sometimes you may wind up stumbling upon something. You find on an x-ray or something that they have an organ that maybe they didn't tell you about. Then you have to have a different conversation with the patient. But I haven't personally run into that scenario yet. All of the patients that we've taken care of, once they feel comfortable with us and understand that we're accepting, they really are comfortable with opening up and talking about prostate cancer care and those kinds of things. So education really is important, because we definitely ran into a lot of situations that, I had one patient ask me when they would get their menses, and we had to explain to them that they didn't have the organs required for her to get her period and have a menses. And so it's really, really important to make sure we provide comfort, inclusivity, and education, lots of education.
Looks like the last question in the chat by Brandy Donbeck asked, you mentioned someone has to live as the gender they want to transition to for a year. Who determines the criteria was met?
We just go off of what the evaluative team goes by. So we're not like, hey, have you been, having your hair cut short or, whatever. That's a gray zone, I think, in the law, right? I think it's very difficult. So we really just rely on the evaluative team to help us with that and meet that criteria.
Okay, any other questions? Well, it doesn't look like anything else is coming in. Dr. Gerretsen, it was a great pleasure having you come out and speak for us on this great topic. And if anybody has any questions, feel free to reach out to myself at programassociate@anany.org, and I can try to answer some of those questions, maybe connect with Carly for some answers that you might have after the webinar is over. Like I said before, the webinar is recorded and it will be posted on our YouTube. Thank you.
Thank you all.